we will go ahead and get started. Reza, do you want to put up your slides?
Do that. Share screen. Microsoft. Everyone sees that?
Yep.
Cool. So leave it like that. Happy New Year, everyone. So I think we're gonna get the wheels greased going into the new year. So I'm sure some people maybe roll in a little late, but we'll jump into let's go back to the beginning.
Since we have such a small group, do we want to start with just some introductions of folks?
Yeah, happy. This is a good idea.
Yeah, so I'll go ahead and start, and then we'll just bounce it around the Hollywood Squares thing. Amber Rogers with Mountain Pacific Quality Health, Mary, and then Reza.
Mary Argonis, Mountain Pacific Quality Health, your technical support.
I'm Reza, I'm a neuropsychiatrist with Frontier Psychiatry.
And Mary, and then Melissa.
Hi, everybody. Mary Schramke. I'm a patient family advisor and board member of the Mountain Pacific Quality Health team.
I'm Melissa Bates. I'm the behavioral health manager in the family medicine clinic at Memorial Hospital, Sweetwater County in Wyoming.
Awesome. Mark, and then Cindy.
Hello, everyone. Mark Mirabella with Mountain Pacific in Hawaii.
Cindy, and then Dawn.
Hi, I don't know if you guys can see me, but this is Cindy Kane, and I'm a chronic care manager at Memorial Hospital.
Awesome. Dawn? Dawn, and then Maggie. Or vice versa.
Hi, everybody. This is Maggie, Mountain Pacific in Hawaii.
Okay.
Good to see you.
Good to see you guys too. Dawn, if you're on, you can say hi or just stick something in chat if you want. And let's take it away.
And where's Memorial Hospital?
In Wyoming, I believe.
That's in Wyoming, okay.
Yeah, it's Sweetwater County.
Rock Springs, Wyoming, southwest corner.
Got it, okay. Very cool, okay. Well, let me pop through here. So yeah, today was more of going to be focusing on communication of findings to patients and caregivers. I know last a couple of sessions too, you guys got a couple guest speakers too. I'm going to see if I can have another one or two guest speakers. I think for next time, we're going to have a guest speaker as well, a local provider in Billings. So here we are with kind of where we are in terms of the curriculum. So we'll jump in, talk about communication and findings to patients and caregivers and kind of go from there. So today, part of the goal was to really answer the question of, you get to the point where you identified something's going on, you've done some kind of screening, identification, diagnosis, you have some information about the residents or patient's state, whether that's now knowing they have Alzheimer's or some kind of clarity about the diagnosis. And lots and lots of questions come up with families, patients and families, but really in this case, it's mainly with families. I'm on calls. I was just on a little family conference yesterday. Pretty much every day, there's little makeshift family conferences. We do now with Zoom, it's a lot easier. I mean, yesterday I had I think people from 3 different states on the call, family members to participate. And the whole point is well, how do you identify, and how do you bring up this topic with families and caregivers, and how do you talk about it? Because I think that's a big challenge. Some of that challenge is just simply time, right? If we're talking to primary care providers, I think it can be a little overwhelming to think about how much you have to talk about in a limited time frame. And so I think this is a really important topic for all staff to learn and be aware of, because it's something we need everybody's help with. and especially reinforcing information over time, because we kind of give patients, we tend to give patients a fire hose of information. And so there's a lot of repetition, as you all know. So, we want to talk about benefits of earlier in time the communication of Alzheimer's, other dementia diagnoses for a person living with dementia. And so for families to understand, well, why are we doing this in the first place? Like, what are the benefits? Because that's a common question is, what's the point? I don't really need the MRI. I don't need this. I don't need that. Because there's definitely a gap in understanding for the average person. Absolutely. What kind of language to use when disclosing a diagnosis? How do you bring this up? Because there's so much concern about you're giving somebody almost like just absolutely terrible news. And so that's scary to do. So that's something we want to talk about. And then recognize that disclosure of a diagnosis is a process more than a one-time event. And so, of course, you've done a lot of work to get to this point. There's going to be more work afterwards. And so we don't need to necessarily get everything out, but starting that process, keeping the avenue open for communication. Oops. So you can see here, only 45% of seniors diagnosed with Alzheimer's are aware of the diagnosis. This is very common. Even that same family yesterday I'm talking to, this was at a nursing home in the kind of greater Billings area. And I'm looking at the chart and I'm saying, okay, this has actually had a pretty confident diagnosis of Alzheimer's. It's actually a patient, very rare, but ended up coming to my old specialty center at University of Washington. So I had a pretty confident diagnosis. No one in the family knew. I mean, it was kind of interesting, right? Like the kids, I guess they weren't there at the time, but, oh, they have dementia. I said, yeah, but do they have Alzheimer's? And then it brought out some of the gaps and they're saying, well, no, I think it's just dementia. And so it's, that understanding of, well, Alzheimer's is a type of dementia. And I was trying to specify what kind of dementia, but a lot of people sort of look at them as separate things. So a lot of unaware, lack of awareness out there. Among individuals diagnosed with the disease, only 33% are aware of their diagnosis. And so, again, very, very low rate. Once they're further along on the dementia spectrum, they might not be able to retain that as well. And so failure to provide proper follow-up care and delivery of diagnosis when given does not always follow best practices or meet expectations. So these are what we want to really stay ahead of, because sure, you're going to give someone information. Well, I don't want it to be overwhelming, like, oh God, what do I have to do now? I have so many steps I have to do now. I have to make sure I follow up about these things. Well, again, it's a team effort. I think it can be done in a way that doesn't need to be overwhelming. You guys can see the slideshow or no? Oh, you can't see the slideshow.
Yeah, you're not on the slideshow view.
Let's see. Oh, I see. Okay. Got it. How about this?
Maybe it's a different
what?
screen.
I think it's trying to do, hold on, so let me do this, because it's trying to do, presenter view and all that.
So Dr. Ghomi, this is Mary Schramke. Can you remind me, sorry, I might have had a little blank out here. Where did you get the data for that? Was that a survey, and what group did you survey to get that rather surprising rate, at least to me, of, not so many people really know that they've been diagnosed?
Yeah, let me try share. I don't know why it's being weird this time. Share screen, and then I think this will work. You guys see that? No?
Much better.
That looks great. Thank you.
I don't know why. So here we go. So let me see if they have, I think usually do they have some, I'm trying, I don't know if, which reference is the correct one. I can confirm, I mean, the references are usually at the bottom of the slides. So I'm wondering if this is the reference, if this is the same reference here. So I didn't look. I'm not sure what kind of. I mean, it was a survey of some sort, but I don't know which particular one. Yeah, I can look into that if you want. But I mean, in terms of my experience, I mean, hundreds and probably thousands now of patients. I mean, this is easily the majority of the time people don't know their diagnosis when I'm talking to patients, without a doubt. On average, I fully go in expecting, oh, this patient was diagnosed with Alzheimer's in 2018, and they have no idea. I think that's kind of the big issue is there's a huge gap. I think providers are just scared to give the diagnosis. So I think there's a gap in communication with patients. I'm wondering if this is the same paper here. So part of it, I think, is maybe, I can share here. Yeah, so part of it is maybe, I think it can be intimidating to give this news. I think people maybe are underestimating how powerful the approach is. So even if you're giving something that feels like really bad news, I mean, I've said this before, is that the experience tends to be overall rewarding. I mean, people are generally very appreciative, and it usually goes overall very well. It's providing the family with a lot of information they didn't have, a lot of ability to plan the future and just understand what's going on. So generally, it's a positive experience. I think there's a gap, like the assumption is it's going to be a negative experience. So I think that prevents people from sharing the information. And then, of course, how you are compassionate in that moment. The diagnosis of dementia is a key moment in the relationship, of course. So uncertainty surrounding the diagnosis can lead to difficulties with communication. That's key there. I mean, we still are in an era of medicine where, unlike going in with a pathology report for a specific type of cancer where it says right there, you have grade 2C, this type of cancer, whatever. That makes any provider staff feel a lot more comfortable, right? We just don't have that in dementia. So, with me, I can give you some level of confidence, but average, okay, I have dementia. I think it's sort of Alzheimer's. I'm not sure. So I think that gums it up a little bit. That makes it harder to bring up the conversation. Persons living with a disease, care partners, family members, and clinicians are all susceptible to avoidance. I mean, sure, there's some of that, but by the time I'm talking with them, and I recognize that I'm in a specialist setting, so maybe it's a little different, but I don't find the avoidance to be that big of an issue. And then this can be counterbalanced by a progressive disclosure process that begins with cognitive impairments first suspected. That's exactly right. So I mean, really along the way, I'm dropping hints. So it's not a surprise, and I'm trying to do it compassionately. So from the moment I meet them, hey, I'm a little worried, like seems like there might be something neurodegenerative, but there's lots of other things we're looking at. There's lots of reasons to be optimistic still, lots of reasons for hope. We just, we did some cognitive testing. I'm a little worried this pattern, might be Alzheimer's. So I just want to continue down that pathway. So I'm pretty upfront, and I think that helps a lot. There's no surprises. You're kind of being honest along the way. And at the time, if you're a staff member working in a nursing home, I think it'd be intimidating because you might see in the patient's chart they've been diagnosed with Alzheimer's or a dementia, whatever, but they haven't been disclosed. And then you're kind of sitting there awkwardly thinking, well, I know this information, whose places, and really we're trying to empower everybody to have this conversation. We can't ask, well, they have to go to their primary care provider because that's just, not feasible, I think, in a lot of cases. Communication of benefits. So as in the longer you know the patient helps. I think for me, because a lot of times I'm coming in and sometimes I'm talking about diagnosis on the very first visit, and that has to be, that's something I have to carefully consider. Because if they don't know me, they don't trust me, you're gonna be careful how that's gonna come across. So I go through and I tie it all together. I try to look at their life story and put it all together so that it's in a way that makes sense to them. If I'm looking at cognitive testing, and again, this takes some level of expertise, of course, but if I'm looking at cognitive testing, brain imaging, like the brain scans, MRIs, I actually pull those right up and share them right on the screen or in person. So I show them exactly what I'm seeing. And so that way they can understand, oh, okay, wow, yeah, compared to that normal brain, my brain is really shrinking a lot right here. So that really helps to kind of bridge that gap so that it's not sort of just like an idea. You can show them some evidence. And so that can be helpful. Of course, shared management of the disease with the individual and care partners. So care partners and caregivers are intimately involved here. I mean, they all have to be present and participating. And then I really try to hammer down the benefits of early identification and treatment, because it does have, we know it has a big impact on people's lives, but I think focusing on this can really help take some of the focus off of the fact that, well, oh crap, I have dementia. But there are things to work on. Some of it's, life issues like advanced care planning, environmental stuff, where you're going to live. There's medications, of course, involved. Lots of lifestyle modifications that can really help drastically alter the course for the next several years. So person living with the disease. So early diagnosis and disclosure are ideal. So again, my experience has been the earlier the diagnosis and disclosure, the better the prognosis, the better they do, the better the quality of life. I think culturally, and this applies to all kinds of areas, right, it's better if they don't know. I disagree with that. I think we've come a long way, and this is across any disease. It's pretty, honestly, I almost never run into someone saying, "Oh, I don't want to know," because there's so many things they can do, and it becomes a motivator. I mean, it really does change things. So if they understand what's going on, their caregiver understands, there's a lot to be done that's different than if they don't know. And so disease is progressive, it's not an all or nothing. So the more you intervene, the longer you try to stretch out that mild early phase so that you maintain as much function as possible. Obviously providing more choice and autonomy, because while they're still cognitively intact, they have an ability to participate they will not have later. Time to adjust, advanced care planning, participate in research. Research is also another thing. If you're in an area, I mean, there's more and more research being done in these populations. So I think access to that is therapeutic in itself. Really engaging the caregiver to participate again without an appropriate caregiver, which is why we rely so heavily on our residential facilities, because caregivers can't do everything at home. So we need our facilities to really provide that extra support. And oftentimes, being in the right place you'll see a boost in that person's in their functioning, because they all of a sudden have the support they need. Again, how to communicate. So with caregivers, especially when they're family members or loved ones, there's a lot of education around understanding how to communicate with their loved one with dementia, what to expect. Common things like, maybe you don't try to correct them all the time now. Maybe, kind of let them go. Because it's tempting to say, oh, well, no, it's not Monday, it's Tuesday. Small stuff like that, because then it can kind of add to some confusion at times. There's limits to that. I mean, obviously you want to keep people with dementia oriented. I mean, I want them to know when it's daytime, when it's nighttime, but we don't necessarily have to. I think when it's a loved one as a caregiver, sometimes those things can lead to arguments, and that's what we want to try to avoid. What kind of support to access, and of course, to the crowd I'm speaking to today, many of you are in the facility, so this is a point where families, whether it was from their provider's direction or the family direction, their loved ones are already in a place with appropriate support. So again, this disclosure. So I would encourage you, if you see a diagnosis and you've identified a gap between the patient or the loved ones, the caregiver's understanding of what the diagnosis is, I'm hoping that you'll walk away today feeling a little more empowered to start the conversation and say, hey, did you guys realize, have you ever been diagnosed with dementia, or did Dr. So-and-so diagnose you? Exploring their understanding and helping them. Well, I think, if you have dementia, there's several different things that you might like to know. And there's some areas to look at. You might even just be pointing them, like the loved one or the patient itself, depending on their functional level to some, resources that are reliable, some like Alzheimer's Association, and just kind of, again, helping move along their understanding. And so obviously this is, in my situation, I'm doing a lot of hinting, like I said, as I'm building up to it. And then once I kind of have a complete picture, I'm sharing that picture. And then I'm continuing to see that patient long term, and not as often, but I'm making sure they're connected to the right support and educational services they need. And again, we can rely on, well, it's not like Alzheimer's Association is a great one, but there's associations for all the major dementias, Lewy body dementia, frontotemporal dementia. So depending on how specific of a diagnosis there is, and if it's a general dementia, I think Alzheimer's Association is still very appropriate. They provide lots of good resources. I think relying on them is absolutely appropriate. We don't need to do it all ourselves. You can kind of even pull it up and go through with the patient or family member together, so you don't have to kind of reinvent the wheel. And again, the more information there and kind of guiding them through, I find families and patients much less distressed. We also have a lot more direction to deal with things as they come up. It really does change the approach to caring for them in residential facilities as well. And big time, I would say they're much more likely to adhere with recommendations with the disclosure. That's definitely true. I find this to be the population that listens to recommendations the most out of any population age group. So pre-disclosure preparation. Again, you guys are gonna be in a situation where you likely have trust. You have a person living with dementia, the caregiver, you probably know them, they've been at your facility for some length of time, so there's a trust. You've seen their records. You've gotten to obviously know them, so you know how they're functioning. And so I think exploring that knowledge, again, appropriate to be asking these questions. Hey, so, whatever happened with, Dr. So-and-so, or did you get, how long have you been having memory issues? When did it start? Is that why you moved in here? Can you kind of understand these pieces? And then that also helps you respect their autonomy and really bring them in to participate into their care. So, you ask these are kinds of questions you can ask in that regard, and also loop in the caregiver so that you understand, well, what are they thinking? What is it they're hoping for? Some people are like, I really wish I could go home, and really helping them understand, well, focus on what's the safest place that you can have the highest quality of life. And maybe that's in a facility. So what do you think the change in your memory is due to? And understanding, again, if they understand the etiology underneath, what kind of testing and diagnosis they've had in the past. And so it's not a bad thing to ask, well, how much did you want to know? Is it something you don't want to know? I don't really go down this path. And by the time people are usually seeing me, they want to know, otherwise I wouldn't be seeing me. So, but I think this is not a bad thing to understand. And again, looping in the caregiver is key. I know that can be hard, especially right now being short-staffed and with COVID spiking again and all kinds of stuff going on. It can make it hard to have space for this. But if you're doing that, I think, I often will say, oh, where's your caregiver? Is it your wife, your daughter, your son, your husband, whatever it is? I'll just call them in, put them on speakerphone, I'll throw them in on the Zoom video, whatever it might be. As much as I try to involve everybody as much as possible. And then recognizing not everyone's going to be as comfortable, obviously pulling up an MRI and going through it. We don't expect you to do that, but helping them, understand that, okay, depending on where they are in the process, moving them to just one step further. Okay, well, you have memory loss, you're living here because of that. The loved one knows, and just helping them understand, well, do you realize it's, we think that you have a diagnosis of dementia. What does that mean? And taking them through that. And again, depending on the patient, of course, it'll be, to customize our approach. Diagnostic disclosure. So again, with dementia, it's hard to give the most accurate diagnosis because oftentimes, especially when I'm seeing folks in facilities, I'm still doing some gathering. So, you might have had a brain imaging from a while ago. Let me grab that from the records, or you haven't had it yet. And so I'm gonna go out and get it because I think it's going to really help move the conversation along and help us accomplish more. So often I will do that. It's let's get the brain MRI, because that can be like an anchor point for me where I can show them it's visual, helps me move the conversation along. Cognitive testing, excuse me, is another big thing. So even if you pull up like a printout, a MOCA or an MMFC, what we've talked about before, all those things can really help people just see objectively, oh, look, like I'm not where I should be. Of course, we try to do our best to provide accessible language. We talk about progression of the disease. And again, this is where the modifiable risk factors come in. So the more sort of pure that Alzheimer's or dementia is, meaning less medical comorbidities, the more optimistic we can be, the slower it's going to go, and the more control the patient's going to have. And so I use this discussion to really motivate, hey, this is the time now to wear your hearing aids. This is the time now to wear your CPAP, to do the exercise bike, to do things like that. And that can really help provide some motivation. And again, we really focus on strengths. I mean, that's most part. I go over the diagnosis, but there's always going to be things you can point out with the patient that, hey, look at these other parts of your brain that are working. Like, look at the things you can do. Look at the ways you are helpful in the community, helping other people. Whatever it is that they enjoy doing, focusing on that is definitely key. We always go through therapeutic options. I think if you're helping move that along, I mean, more often than not, for sure, even patients that have the diagnosis of dementia, I see in the chart, they're still not being treated with what some of the bare minimum things. I mean, that's just not happening. Like the most patients I see with like Alzheimer's, for example, I don't see them on donepezil or memantine. So there are things to be done, and I think that can also provide some benefit. Just taking time, making sure they're absorbing it. There's going to take some repetition. Again, can be in small doses, doesn't have to be all at once. And I do try my best to write things down, provide some summary. And this is where you can rely on Alzheimer's Association for some of those resources online. You don't have to obviously, again, invent this yourself. But so I'm pointing people to those resources, and I'm writing things down, and then I'm making sure their family, I'm trying to get it to everyone that's involved. That way everyone can help out and reinforce that message. Right. So, I don't minimize. I always say something like, I know it feels like, well, we're talking about Alzheimer's, and it might, obviously it's a very serious thing. It's like, it's not unlike talking about cancer or other serious chronic, possibly life-threatening decisions. And I'm pretty upfront with folks about, well, this is a neurodegenerative disease. This is something that's progressive. We can't cure it. We can't stop it. So I try to balance, full disclosure, honesty, but with compassion, and then a real focus on the positive. And so again, focusing on strengths, what's preserved. Living with dementia. So what do? We have, and especially if you're in a facility already, well, you already have access to a bunch of resources, and I really want to optimize that and really encourage people to take advantage. And how do we delay the deterioration, improve quality of life? That's really the key here. We absolutely have the power to do that. And then so for follow-up, and I think in a situation with facilities, and you're working, if you're staff in a residential facility, I think it's easier to have this ongoing discussion, right? There can be some facilitation with their medical providers. Hey, who's rounding on the patient, the local provider, they're going out to see putting that on the agenda, and making that a topic that's going to be discussed. Bring in help. You don't have to be the only one. You can absolutely be the advocate, you can be the champion, but you don't have to obviously do it yourself. Have the primary care provider, the inpatient person, whoever it is, also discuss this a bit. And if they need some education, well, we're here to provide that. But this is an opportunity to share more information. And so these are all things I kind of do over the long run. I always review medication, side effects, and questions. Sometimes certain topics need to be reinforced, the lifestyle modifications. Well, and I try to build one habit at a time. Like with this lady I saw yesterday, I got her daughter to send her a little mini stationary bike, the ones that you can just use sitting down, because with COVID, she just couldn't go to the exercise room. And so we did that. And so checking out, so I try to do one thing at a time. It's not overwhelming. And that's, that's a big improvement by itself. Treat any underlying or just explore, but sometimes we want to treat if it's causing a lot of issues. Sometimes, depending on how far along with dementia you are, certain underlying anxieties can turn into behaviors that are confusing for others to watch. And might say, hey, they seem really agitated. Well, they're anxious about something. We just don't know what, and their ability to communicate is limited. So we have to do some exploring. Caregiver stress is a big one. And it's no different than if you're in a residential facility. So if you're a staff member, I consider this to involve your stress level too. That's why I want to make sure staff feel supported, because it's a lot, right? Whether you're working and getting paid for it or your loved one at home, taking care of someone with dementia is an incredible amount of work. Sorry. And then we kind of continue monitoring. We don't really typically need to do like follow-up scans, unless there's like a sudden change that's just really out of the ordinary. But we continue with education and making sure that we're just being vigilant, because there's a lot, again, things that are different, like watching out for infections that may not pop up in the usual ways. Someone's behavior might change, and it might be delirium because of some kind of infection. So being vigilant about that is huge. And so here's a little chart, just kind of, again, just almost like a graphic, just to think about what we just talked about. And so patients, a family, clinician, I think really a clinician is any staff member, because you really have the power to bring these kinds of things up. And if you don't know the answer to something, that's okay. That's something you can use to prompt for their next visit, their medical visit, and who they're going to see next, or might prompt to schedule a visit. Say, what, let's get you scheduled to see your provider, or bring in a specialist because we need some help talking about this, or pushing them to the Alzheimer's Association or their local organizations, senior care type of groups, because there's going to be people around that have already been through this. So I think in residential facilities, you're going to have patients that are many are kind of before disclosure. They're definitely in this bucket here. And so we're focusing here because, like we saw, more than half of your residents probably don't know that they have the diagnosis. And so there's some preparation work to be done, and then some facilitation, bringing in some additional care support to make sure they get on the right treatment plan, and then some ongoing follow-up. I think that's the last slide there. Any questions? Do folks, like kind of the staff on the call here that work in facilities, I mean, what's your comfort level? Like if you saw, you had a patient you were getting to know, and you saw in their medical record that they had a diagnosis of dementia, but you were sort of sussing out that they didn't really know it, or there's just kind of a gap. I mean, where's people's comfort level in addressing that? That makes sense.
I feel pretty comfortable.
Cool. Cindy, do you mind like just, can you think of like an example or a case?
So for me, I feel like it's more on the family member that's helping them the most, more talking with them, because with my patients that I have, they've had dementia, before I started. And most of the time over the phone, I'm talking to their POA or, someone other than them. So I think when I first start, a lot of the times my patients or their family members don't understand any of their diagnoses very well. So when I very first get them on like chronic care management, excuse me, one of the things that I do is I just say, so you have this diagnosis. Can you tell me about that? What does that mean? And just kind of what you said, and go through each diagnosis and then decide. Sometimes I find out that they completely disagree with that. There might be something that they're like, oh, I don't have that, or it's something where they're like, oh, yeah, I don't know a whole lot about that, but I do know this. And so I just try to fill in the gaps with that. And it's the same thing with dementia. If I see that on there, just assessing, what do you know about this? Or, and what I've actually seen with dementia more is that the patients don't actually bring it up or say a whole lot about it when I have mentioned it. It's more their caregivers will.
Agreed. No, that's great. Yeah. Do you ever loop in the provider? Like, do you ever say, oh, okay, I think you should set up an appointment to talk to, your provider about something specific, like if it's like you ever get concerned that, they're on the right medication or kind of a treatment plan issue?
Yeah, I do have them a lot of the time, especially in Rock Springs, they just go too long without getting reevaluated or seeing any provider. There's a big gap. They'll write their medications for a whole year with refills, and then they just won't go back, for a long time. So when I talk to them every month and I'm like, okay, well, I think that you should see so-and-so provider because of this. And then they're like, oh, okay. And then I just schedule it for them. And it works pretty well that way. So yeah, I do see that. Now, as far as like medication changes, just because I'm a nurse, I don't really feel comfortable talking about that, but I do say things like, well, it looks like, your blood pressure has kind of been creeping up a little bit. We've talked about eliminating salt in your diet. We've tried things that I can help you with. Maybe we need to bring that up with the doctor and maybe ask about your medications. So, I mean, there's that way, but, as specifically saying, and I don't even know with dementia, honestly, I probably wouldn't be able to look at it and be like, oh, they're missing this medication, that I think I'd probably need a little bit more background to know why providers sometimes will prescribe this or won't prescribe that,
Yeah, definitely. And yeah, that's kind of, a little bit of in the curriculum we're getting into here without getting too far into the weeds, but yeah, we just want to be able to identify those gaps and then bring in the right resources. So, so that's awesome. I mean, so you're doing I think that's a great model. I mean, that makes a lot of sense. You have some resources to bring in.
One thing though, I don't mean to interrupt, but one thing that I kind of feel that there's a gap as well is sometimes I don't know how much the individual providers will know about a specific thing, especially with dementia. Like we did just get a neurologist in our hospital, but even knowing, like, I think it's kind of a struggle, Melissa can talk about this too, is like when we have someone where the providers are trying to, like we've asked, okay, they have to sign consent for this program. Does this person, like, can they really sign consent? Where is that line? And having the providers kind of step in. I feel like some providers are really good at saying, okay, yeah, this is obvious. And then sometimes it's very gray and they don't know what to do. And so that's kind of a thing that I see is just kind of knowing where they are and what level. And because we work with family physicians, so not neurologists, so it is kind of hard. There's that area where it is hard. And sometimes I feel I know more and it's kind of hard to say, hey, well, what about this? I'm not sure if they really have consent. So trying to have that communication with the provider, but also both of us not really sure,
Yep. No, that's a very good point, because as a staff at whatever level, understanding where the provider is absolutely true. Because again, I wish there was an easy way to spread me across everybody and make it easily accessible, because there are so few of me. And then, you got, your primary care provider, and then some of them are a little more focused on geriatrics, some of them not. And so, yeah, they're gonna have more limited understanding. You've got your general, some psychiatrists have a little more understanding, some general neurologists, but even then, I mean, general neurologists, are not necessarily that much more specialized than primary care. But then you have your dementia focused doctors like the geriatricians, or like behavioral neurologists, neuropsychiatrists like me. And so that's like our whole view. So yeah, I wish there was not as much of a gap, but that's a very astute observation to kind of recognize where that gap is and then try to help fill in that gap. That's a delicate dance for sure. We don't want to obviously step on toes. We want to kind of give some guidance. And that's where some of these resources, helpful to point to. And honestly, we'll do our best. I mean, Mount Pacific, we're working on ways to target education some more too. I'm working with, specifically, there's a whole kind of nursing home group within the organization. So we're looking at how do we provide, like that kind of information, those didactics you're referring to like the providers or, people on the front lines. So that is definitely an ongoing issue. Anyone else with experiences talking with patients or families with dementia and anything that you remember?
I've done some teaching and providing education with some of my patients and the caregivers about the things you'd mentioned about just maybe not correct every time. There are some things we don't need to argue about with people. I think I don't feel comfortable being the first one to tell a patient that diagnosis if they didn't know about it, but I do feel comfortable providing some education on the process of the disease. I have gone back to a primary care provider and had them schedule an appointment with a patient to try to give a better prognosis of like, where does this go? It's a progressive disease. It's not going to get better. We can expect that it's going to get worse over time. Just to have people have some reasonable expectations of where they're going.
That still goes a long way in helping progress that conversation.
This is Amber. One thing, my mother had dementia, and looking back on it now, I mean, I knew that she had dementia, and me and my father talked about that, but as a caregiver to her, it would have been helpful because you kind of forget that you're a nurse when it's your mother. It would have been helpful for the provider to prompt me about how to remind my mother that no, we're not doing that now because give me some extra helpful hints in redirecting her. She was quite obstinate.
Knowing how to handle that gently is a big step. And one of the things you might be observing is that interaction between the caregiver or the loved one and the patient, and helping them just kind of gently guide that, because think about it, they have a lifetime of habits, right? And so it's hard to change their approach, but that can really provide a much more peaceful environment.
Yes.
Any other comments? This was kind of main goal today again, was trying to arm you with a little more comfort and motivation to identify these knowledge gaps and start the conversation with patients.
I have a question. I don't know. I mean, it is related, but not directly related. You had talked before about the anticholinergics. Do you still see that when it's just the lung specific, like for COPD medication?
Say that again, the COPD one?
So you had said before about how, to try and get them off of the anticholinergic type ones. And so is that still the same recommendation for like, if they're on a COPD medication that's an anticholinergic, like the Spiriva, I think it is, it's just going towards the lungs more, but I don't know, it could get into the bloodstream. I'm not really sure if that one's.
Yeah, most of the asthma medications they're not as much anticholinergic, so I'm not usually it's not ideal. Like tiotropium, Spiriva, yes, but if it's like just the inhaled one, I guess it just depends on how bad their COPD is and how much they need it. If they can use like beta agonists or other types of medications, great. If they absolutely need their Spiriva and it's inhaled, I'm not as worried. But yeah, to your point, some people do take the tiotropium pill, and I do try to avoid that. There's the Spiriva, but it's still going in your system, but it's not as bad.
Thank you. That's what I thought, but I just wanted to just clarify and make sure.
Yeah, for sure. It tends to be more like kind of bladder medications, things that you're taking systemically. Really try to avoid.
Well, if there's no other comments, we can give you a few minutes back in your day. And thank you all for attending.
Thanks a lot.
Thank you, everyone.
Thank
Bye-bye.
you.